So I think this was meant to be a student or a trainee section, so you're probably looking at me and saying, isn't she a little bit too old to be a trainee? Well, today I'm actually representing the group that's come up with this ancillary study. So it's really my postdoctoral fellow, former postdoctoral fellow, Amanda Hudson, who came up with the idea for this study, so I really want to give her a lot of credit. She's just had a baby, so that's why she's not here presenting herself today. So I'm going to be presenting about an ancillary study that is part of the Optima trial. And for those of you who were here last year, you've heard a lot about the Optima trial. I'm going to do a little bit of a review for those of you where this is something new. So the background for this is very much as we've heard in the last two studies, but we know that North America is really in a prescription drug opiate crisis right now, and really high increase in the rate of prescription opiate use. One study suggesting, that was done in 2014, suggesting 185% increase in prescription drug use over the last decade. And obviously we have an increase in associated harms, including increased rates of dependence, increased rates of overdose, hospitalizations, and even deaths. And so there are many social, interpersonal, and economic costs, making studies of how we can best treat people with prescription opiate dependence a real priority. So what we need to do is evaluate the effectiveness of different types of opiate substitution treatments for people who are prescription opiate dependent. Now, in Canada, methadone is really the standard of care for people with opiate dependence, and it's provided under supervision on a daily basis for 2 to 4 months. And that at that point, patients who meet criteria, those who have been consistently testing negative for use of illicit drugs and meet other provincial guidelines, they're given the opportunity to be carriers or have carries privileges where they can receive take-home doses at their physician's discretion. In contrast, an alternate opiate substitution treatment, which is buprenorphine naloxone combination, it's prescribed on a more flexible take-home schedule, and treatment regimens vary on a case-by-case basis. Most of the research that's evaluated methadone versus buprenorphine naloxone has employed controlled schedules for both types of treatments rather than comparing the way that they're really used in clinical practice. So that really limits the generalizability of the findings to real-world or ecologically valid treatment scenarios. So the Optima trial was designed to bridge that gap by examining in a controlled way, in a randomized trial, the effectiveness of randomly assigned buprenorphine, naloxone, and methadone while employing usual models of care that comply with each drug's respective safety and clinical guidelines. So this permits a much more ecologically valid design, like comparing how these drugs are used in clinical practice. The primary outcomes of the Optima trial are treatment retention and compliance. So is there any difference across those two different types of OST treatment in retention and compliance, and also abstinence from illicit opioid drugs? But there are a number of secondary outcome measures being assessed, and the ancillary study that I'm going to be speaking about today is focusing in on sexual functioning side effects as an important aspect of quality of life for the outcome of these two different models of care. And so the project, the ancillary project that I'm presenting today, really builds on the Optima protocol by including a small number of additional secondary outcome measures that are focused on patients' sexual function. So we're looking at sexual desire, sexual arousal, orgasm, pain, and sexual satisfaction, as well as distress about sexual functioning. So why sexual dysfunction as a secondary outcome measure in this particular area? Well, first of all, it is a very important aspect of everyone's quality of life. And we do know that sexual dysfunction is well documented among men who are taking methadone, So there have been a number of studies to establish that. Specifically, men taking methadone experience increased rates of erectile dysfunction and reduced sexual desire. And this is thought to occur as a result of methadone-induced hypogonadism. These side effects are concerning because it's possible, theoretically possible, that they might contribute to people deciding not to take their medication, so not to comply with the regimen or even dropping out of the treatment. And we know that that has happened, that's been established with other types of treatments that have medications that have sexual side effects, so antidepressants and antihypertensives. But this hasn't really been examined in the OST area. Several non-randomized studies that have evaluated sexual function in men who are receiving OST have found poor sexual functioning in those who take methadone relative to those taking buprenorphine and naloxone. But this hasn't been yet examined in a randomized controlled study, nor has it been examined with ecologically valid dosing schedules. So the Optima trial really gives an opportunity for us to examine this in a more ecologically valid and more controlled manner. Research on sexual dysfunction in women taking methadone is scant, but there is some preliminary work indicating that several dimensions of sexual functioning, of women's sexual functioning, or arousal and orgasm, for example, may be negatively affected. So one Reamer shows that. So the current trial can build on the limited knowledge that we have about women's sexual functioning and how it's impacted by opiate substitution therapy. And no studies have examined the relative effects of methadone versus buprenorphine naloxone on women's sexual functioning. We also know that women have higher access and retention rates in opiate substitution therapies than men. So it remains to be determined whether the higher dropout rates that we see in men might be related to more severe sexual side effects in men, or greater impairment due to those sexual side effects, so greater impact of those sexual side effects in men. So the Optima trial really appears very well suited to build on the work that's out there on, what do we already know about opiate substitution therapy and sexual side effects. Using more real-world models of care and allowing us to assess the effects of OST-related sexual dysfunction on treatment compliance retention. And that research question really hasn't been addressed in this area at all. So linking what happens with sexual function to compliance and to dropout. And so it's really going to build on the limited knowledge that we have also for sexual dysfunction in women who are taking methadone. So just to review, the objectives of the three main objectives of this ancillary study are that the proposed project is going to build on research comparing buprenorphine, naloxone, and methadone effects on sexual dysfunction in men, using a design that embeds these different treatments for prescription opiate dependence within an ecologically valid model of care. Second, the proposed work is going to determine the relative effects of buprenorphine, naloxone, and methadone on sexual dysfunction in women. This is a population that's been largely overlooked in the literature on opiate substitution therapy-related sexual dysfunction. And finally, we're going to try to link OST-related sexual dysfunction, if we see it, to treatment attrition and non-compliance. So the first study to do that. So how are we going to do that? I'm just going to briefly review the important parts of the protocol. So in terms of recruitment, the ancillary study is recruiting from all 4 nodes where the Optima trial is taking place, so all 4 nodes across the 5 sites. The men and women between the ages of 18 and 64 who have a diagnosed opiate use disorder as per the DSM-5 are eligible, so all Optima trial participants are eligible, regardless of whether they're sexually active. So that's part of our research question, is whether it's affecting sexual activity. We're going to gather their data through the Optima trial electronic data capture system. At screening, participants in the Optima trial are going to be informed about all the ancillary studies, and those that are interested will complete sexual functioning consent forms at screening. Then they're going to complete 5 different questionnaires at baseline, and then 4 of those will be completed every 4 weeks during the 24 weeks of the follow-up. And each questionnaire takes about 5 minutes to complete. So about 25 minutes the first time and 20 minutes each of the 6 additional times. And they get compensated with a small compensation each time they complete the measures. So what are the instruments? Just very briefly, we're looking both at baseline and follow-up in basic sort of sexual function, demographic measure on their sexual activity, any medications that they're using, their relationship status. Sexual orientation is just assessed at baseline, and that is also looking at their biological sex, because that determines which sexual functioning measure they complete, whether it's the one for females or the one for males. These are all established psychometrically sound measures. We'll also look at their sexual distress and their global sexual satisfaction. To just speak about what the sexual function measures look like, the female sexual function index is a 19-item measure that looks at desire, subjective arousal, lubrication, orgasm, satisfaction, and sexual pain. The male measure is the International Index of Erectile Function. It includes questions on erectile function, orgasmic function, sexual desire, intercourse satisfaction, and overall sexual satisfaction. So because we're using different measures for men and women, when we analyze them, we're going to be standardizing them so we can put them together in the same analysis. So that brings us to our analysis plan. We'll be analyzing the data in a 2 by participant sex, by treatment group, buprenorphine, naloxone versus methadone, by time, mixed model ANOVA, and we're going to look at, it says 3 outcome measures, there's actually 4, just sexual involvement is another outcome. So female sexual function, or the International Index of Erectile Function, will be one set of outcomes. So their sexual function, their distress, their sexual satisfaction, and then just their sexual involvement as well. And then we'll look at possible moderators in a secondary set of analyses, so whether or not they're sexually involved, whether they're taking any other medications that could impact their sexual function, are they in a relationship, so do they have more opportunity for sexual interactions. Then to address the question of whether there's impacts on compliance, with the medication schedule and also dropout, we're going to be looking at something called a moderated mediation analysis. Sounds complicated, but what we see here is, does treatment condition have an effect on dropout or compliance? And if so, is that mediated through sexual dysfunctions caused by one of the medications over the other? And is that further moderated by sex? So for example, are we seeing greater effects of methadone amongst men on sexual dysfunction, and is that leading to greater dropout or treatment non-compliance in the men taking methadone? It could be one potential outcome of that analysis. So the clinical implications, results will help inform clinical decision-making around the most appropriate models of care for opiate-dependent men and for opiate-dependent women, and it considers sexual function as an important aspect of what we should be considering and making those clinical decisions. And it might help also identify an important contributor to OST dropout and noncompliance. So if we know more about this being a big issue for men who are taking methadone, for example, we might be able to do things to help them manage that so that they're not dropping out of treatment or not complying with their medication regimen. And these are all the people here that I would like to acknowledge and thank. We're really excited to get going on the study imminently. So any questions? Yes.
Do you consider including measuring testosterone levels in male patients? To have
It's
an
not
additional...
as part of our study, so I'm gonna, I don't know if Didier is here. We're not. No, we're not. So the ancillary studies are studies that are attached to the larger trial, and they have a limited budget, so they're things that are added on as additional interesting questions. We might not be able to address everything within an ancillary study, but it's a really nice opportunity to at least get going on an area, so there will be limitations.
because in methadone patient, sexual dysfunction in men is potentially reversible with treatment. It's very often neglected during the follow-up. So
you're saying, so you're saying some of the men would have had this treatment. Well, we should definitely, thank you very much for that input. We should very definitely be asking them that question at least, yes.